Hey everyone. Well, we always have a busy agenda for a 1 hour meeting, so let's go ahead and get everything started. Good morning. Thank you for joining. This is the Behavioral Health Urgent Care Work Group meeting. This one is rescheduled from our meeting a couple of weeks ago, so thank you for being flexible and rescheduling today. My name is Jeff Vanderplug. I'm the CEO of the Child Health and Development Institute, and I'm co-chairing this morning with Tim Marshall from DCF, who is on the line. Just so everyone knows, the meeting is being recorded. Leah, I believe that the meeting recording already started. Is that right?
Yes.
Great. And if you wouldn't mind taking minutes for us this morning, that would be great. I appreciate that. So as we started here, let me just pull up the agenda in case somebody doesn't have it in front of them. Okay. So today we will be kind of continuing our work group goals that are set early on in this process, understanding the landscape of federal and state initiatives, expanding the crisis care continuum and other core components of a crisis continuum for children. We want to draw on the literature and expertise, including all the Connecticut-based expertise. Next week, actually, we'll be having a presentation from a couple of model developers in New York State. So we'll be excited to hear from them next week. And then ultimately, we're making recommendations to the Children's Behavioral Health Implementation Advisory Board, as well as the 12 State Department commissioners. So just in terms of further context, I'll turn it over to Tim.
So good morning, everybody. Appreciate you all joining us. Looks like we're just approaching about 20 folks, which is a great number to have. Just a reminder that the recommendation for Connecticut to develop behavioral health urgent care centers has been in our children's plans for the last 7 years. And so it is at a point now when Connecticut is trying to make the decision for implementing and going forward. So it's been there for 7 years. Nothing against emergency departments. They do a fabulous job with the resources and the work that they do, the primary work, obviously, for medical. And as we've seen children's mental health issues raised across the country in the last number of years, we've seen an explosion of the number of kids who are going to emergency departments for mental health needs or behavioral health needs. So when we're talking about an urgent care center, we're talking about, for lack of a better words, is if emergency departments had endless resources and were fully staffed with a full complement of medical doctors and a full complement of behavioral health specialists, and a child walked in and they got the best assessment right away, we're talking about that period of time of a 3 to 4 hour assessment at most. And then if the system is healthy and working, a decision tree where there's an opportunity to refer to back home, safe and secure, an alternative to home for some other reason, crisis stabilization that just needs a little bit more assessment, maybe over a handful of days up to a couple of weeks, or inpatient, and in Connecticut, maybe a PRTF. So really what we're just trying to do is to say, what do we need as part of our best practice in Connecticut? So that's been a part of our recommendations for the last 7 years. And the second piece that's really kicked this up has been the national movement for the 988 system, which we're now only 11 months away from. And in all of the distribution of all the best practice documents that the feds have been sending out across the country to every state, was that every state should be not concerned solely with the 988 dispatch centers and all that, but your full crisis continuum, of which they describe the urgent, the behavioral health urgent care centers as an alternative. And then as another option, the crisis stabilization that goes from 1 to 14 days for an extended residential crisis stay, if you will. So today we're going to be focused on what we think you all would like to see Connecticut have if we were to implement this tomorrow, and to be sure we're not running interference with any procurement issues at all. We want to just suggest and talk about those best practices that you all believe we should have in Connecticut as we go forward with a possibility of implementing this kind of level of care. So that's where we're at. We are looking to have some folks join us next week for our third meeting. And again, I agree with Jeff and appreciate your flexibility. It was a short window of needing to cancel that last meeting and reschedule for today. So appreciate everybody's flexibility on that. So with that, Jeff, I'll turn it back to you.
Okay, thank you. So any other questions before we get in? We have a work group activity scheduled. Hopefully that you got that document that was distributed with at least the beginnings of some ideas, understanding that it is not in any way set in stone. I just think it's helpful with work groups to have something to respond to instead of starting totally from scratch. So hopefully you had a chance to look that over. I will put it on screen share. But before we get into that, are there any questions from anyone before we get going? Okay. If you have questions, feel free to, oh, Barry, I think I see your hand. Go ahead, sorry.
It's overall, just comment, it's hard to understand where is the state with what mobile crisis's role is and is going to be. I mean, because otherwise, like putting all the rest of this stuff in context, it's hard to visualize these models without understanding that and the interface between what 988 and mobile crisis for children.
Sure. So thank you for the question. Appreciate it. And yes, the vision with that, with this would be, and if we know it was an incredible burden, but we did send out a ton of documents where they speak to this. But the vision that has been put forward for now a number of years is that with the crisis intervention system, the whole array, the main gatekeeper, if you will, is mobile crisis. So that mobile crisis would have direct access into multiple levels of care in terms of the best practice. So again, some of those things we would need to work on and reduce some barriers that get in the way of that. We have had some limited success, not nearly as successful as we had hoped with what was originally supposed to be direct placement and access from mobile crisis into, we had two just crisis stabilization programs in the state after kid care. We never had a full implementation of a whole level of care across the state on that. And then some similar struggles and or minor successes on SFIT, where there was the possibility of direct referral and direct admit into those two levels of care. So we would see and hope to be able to bring a couple of other components that would enhance the whole crisis intervention system. And so if you go to the end of the document that Jeff sent out, you will see that, again, there's the notion that the behavioral health urgent care center and the mobile crisis, crisis stabilization, inpatient hospitalization, PRTF, are all intimately combined and connected. And one of the challenges we've had in Connecticut is they've all been very separate and unique and somewhat fragmented, if you will, or not as integrated as they could be. So the vision and the best practice documents really suggest that mobile crisis have geolocation, real-time access to appointments, scheduling for across this service continuum, as well as direct admit practices to multiple levels of care, including the crisis continuum. So again, these would be iterative steps and enhancements that we would like the system to be able to make. But essentially, this would be a part of an integrated. The plan would be to make the behavioral health urgent care centers an integrated process to the rest of the crisis system, if you will. So we're talking exclusively today, but you're right, Gary, it's really hard to talk about them. And by the way, their relationships to emergency departments, all of these are interconnected. So really need to talk about relationships and interconnectivity between emergency departments, any of these that would be developed, from these to any crisis stabilization units, from there to any inpatient beds, from there to any PRTFs, and the different ways that kids can go, because kids can come flow in multiple directions.
So I will just add to that and say that based on Gary's comment, and I'm sure your perspective is shared by others on the call, I would recommend that as we pull together our best practice document, that one of the sections that we add to it would be how this behavioral health urgent care level of care fits within the rest of the crisis continuum or the overall behavioral health continuum, so that there's at least a clear articulation about how those relationships work, and it's not just a best practice document about behavioral health urgent care in isolation from other parts of the system.
Jeff, this is Carl Schissel from CHA. I'm also one of the tri-chairs of the Implementation Advisory Board, so I'm wearing two hats, and I'll be careful to let you know from which hat I'm speaking. This is the CHA hat I'm wearing right now. You know, the reference to emergency departments, I think, is appropriate and terrific, you know, but there are also other points of access, you know, into the system. And so, you know, as we talk about access to the urgent care centers, I think it's important for us to keep in mind the need to interact not only with emergency departments, but also with urgent care centers and primary care physicians, you know, from the provider side, and also, I'm sure for consumers, you know, for the patients and their families, it's going to be challenging to figure out the differences between, for example, an emergency department, an urgent care center, and a place like this. You know, so I think from not only the consumer, the provider perspective, but also from the consumer perspective, I think we need to think about how we educate the world about what this is and how it fits in. So thanks, Jeff.
Yeah, thank you,
Yeah.
Carl. Those are all excellent points. Tim?
Yeah, I just thank you, Carl, because I didn't intend to leave out. So mobile crisis is clearly a main player and a strong glue. And in fact, the terms that the feds tend to use is like a hub center or coordinating center, or they kind of use the analogy of the air traffic controller, but that they are not exclusively the doors in. So walk-ins and multiple others, as you articulated, are all really important. And yes, I think the other piece is to be clear that we really need all doors, all avenues in reciprocal, respectful communication and collaboration going each direction in all those different avenues you mentioned. So I appreciate that. Thank you, Carl.
We're already really diving into the referral and acceptance section in a lot of ways. As folks, hopefully you can see it on screen share. If you can't, let me know. Looks like it's working from my end. But you can see a number of bullets here speak to at least some of these issues. The idea of behavioral health urgent care coming out of the SAMHSA best practice document really speaks about behavioral health urgent care serving as a no wrong door access to mental health and substance use care for all children, regardless of system involvement or payer, which I think is a really important concept. It's closely connected with the next bullet, which speaks to a no reject policy. Now, there may be, of course, children and families who are not appropriate for the behavioral health urgent care and perhaps belong in a emergency department if there is imminent risk of harm to self or others, for example. But then on the community-based side, there's also taking in referrals from, as we were speaking about before, directly from mobile crisis, directly from youth and family who walk in, but also, I think importantly, the first responders is a significant part of the best practice literature out there. So ambulance, fire, police, for example, need to be able to refer to this behavioral health urgent care as an alternative to the emergency department. And perhaps that would all occur in collaboration with mobile crisis, who can help make appropriate triage decisions. And also 988 and 211, I think, will also play a role in that as well. And then, Carl, to your earlier point, you can see here primary care physicians, and also, I think, very importantly, schools in that second bullet, since schools tend to be high referrers to the emergency department. So let me just pause right there. And I see Jason has his hand up. If you want to take yourself off mute, Jason. There we go.
Guys, hope everybody's having a good day so far. I just wanted to ask for a little bit of further, definition on what y'all consider in this to be imminent risk of harm to self and others. That's a pretty broad kind of term. And I know that we see between 20 and 40% of kids being high risk for suicide when they enter the ED. And I think that that's, kind of gone up and down. But what does that mean? Because if that's, just utilizing scoring tools, it makes it very complicated for any of those kind of listed referral sources to be able to then refer and know who they're allowed to refer and who they can't. Or is that just somebody that's like, bleeding because they have a medical need that resulted from, self-harm? Just looking for further clarification on that one.
I would like, honestly, and I know it's always feels terrible when somebody does this to me, but I like push it back on you, Jason, because I would love to hear more from you about what you think, how you would define an imminent risk of harm to self or others. Since that's listed as an exception for urgent care, I think it'll be important to know how we clearly define that population of youth. So just kind of tell me more. That's my request.
Yeah, I mean, I would encourage someone to disagree with me on this, but in my mind, EDs are in no better place to handle someone that is suicidal or homicidal than a place that's dedicated towards it. If someone has a medical need associated with it, an ingestion, something like that, by all means, it's not without a question where they belong. But someone that is saying they want to hurt themselves, I think a site designed for behavioral health intervention is going to be in my hope would be in a much better place to care for that and help them than an ED that's primarily focused on the medical treatment of patients. I think every ED is a little different. Some may have more resources to handle something like this than others, but even more so, the reason that something designed to handle this, I would hope that it would be just the medical side of risk that would be the exception rather than harm to self as they say, as someone saying, I want to hurt myself or I'm going to kill you, be the exception, because I think that would very much complicate it if that was the case.
Yeah, I appreciate. Thank you very much. And we have historically operated that way, both with the script at United Way call center. And the shortest hand has been blood or weapons, are the ones you're calling law enforcement or you're going directly to ED are very clearly, and there are others, but your starting point is there. So I think that's where our beginning point is. I see Carlos, Dr. Gonzalez has his hand up.
Yeah, I'm kind of glad we started at this particular place because it is kind of one of the critical points in the whole thing. I agree that, it says here, no wrong door access, with the exception of youth at imminent risk of harm, etc., who should be referred, but that's going to require somebody very expert and to triage, we can't leave that to EMPS folks. So that would be kind of it says here, medical clearance is not required prior to BHUC utilization, but staff should have the ability to assess whether an individual's condition requires medical attention in a hospital, etc. But this is medical clearance. So you're going to need somebody at the front who is,
right,
well-versed in both the medical and, social aspects of crisis. Without that, then you really do have kind of people ping-ponging back and forth.
Right. So my reading of the literature on this point, the far majority of programs that have been implemented do a quick medical screening at the door. And what a number of jurisdictions have done is literally they kind of get met at the door. And if they're coming by ambulance or by whatever way of transportation is occurring, that has to hold until the medical clearance at the door is done. And often it is, as I said, it's a nurse practitioner, but some I did read have some hours of physicians or PAs is my understanding. So I think the literature and the best practice do call for that. Obviously, this implementation of this requires legislation to allow law enforcement, EMTs, paramedics, et cetera, to be able to go to these locations versus the emergency departments. And then again, in that legislation, again, often jurisdictions address with some legislative language around this issue. So again, you can't get too complicated in legislation. It really does need to get played out on the practice side. So I think what you guys are all highlighting is these are the areas that we need to be very clear about our operational definitions and exactly what we mean by these, and then how practice is, how our behavior is, and the practice is informed by these decisions. Look, Steve, did you come off for a comment?
Yeah, I was just gonna tack on to both of those comments. I think the key word for what Jason was talking about is the structure or the facility needs to be adequate. So yes, you can send suicidal kids to this type of urgent care center, but the center itself has to be physically designed in the right way. And then in terms of this idea of triaging, in an ideal situation, it would be in close proximity to an emergency department. So if you have missed a medical, issue, meaning an ingestion, I think would be the most, common thing. And they're doing their screening and the person's intoxicated, they notice or they reveal that they ingested a bottle of Tylenol, that you're not losing time and getting, at least not much time in getting them to a medical facility. So there has to be a sort of an awareness of both, physical space as well as geographic location, and tying the ED into this system as opposed to making it the stopgap that it is now.
Yeah. Again, appreciate your comments. And actually, Jason, I'll come back to you in a second on this, because so in my reading, again, of the literature of those that have been implemented, the large majority are very close proximity to hospitals, sometimes on hospital property, sometimes adjacent to hospital property. And Jason, I was just curious about the one you were involved in. Was that a hospital-based one, or is it on a separate property?
It was a hospital based, but it was on a separate property. So both. It was run through a hospital, and it was about 15 minutes away from the hospital.
Yeah. So we would love, I think, I think there's certainly a lot of capacity here for exclusively kind of the provider community to potentially do this, but I do think it's difficult. I think a combination of hospital kind of provider kind of combination could be ideal in these situations. Again, from the literature I've read, there have been some behavioral health providers who have actually been the ones to perform in the urgent care center, which is on hospital property or is hospital property. So there's been a combination, and then sometimes they're staffed by both hospital staff as well as behavioral health provider staff. So I think the other, Jeff, understaffing, it could be, again, this issue of, different levels of expertise kind of collaborating and trying to figure that out. But if people have concrete recommendations about that, we're all ears on that also. But thank you.
I just want to mention, to go back a little bit, because you're making notes, so I feel like I have to have a note on this one. But it's around the method of arrival, and there's the talk about EMS and police. In my mind, without that, this won't work. The amount of patients that come to the ED via EMS and police is more than 50%. So if there's not that legislation around being like that true referral arena, I don't see this being ultimately overly successful. So I think it's a very important aspect of all of this.
Jason, are you speaking specifically to those first responders?
First responders in general is a great way to put it. Someone that, if the school, which a lot of times it's the school or a home, calls 911 and they have a kid acting out, and police, whoever, first responder, transport them, they need the ability to skip the hospital and go to this center if appropriate.
Yep.
If they can't do that, we're just making the ED another place to stop along the way, and they're not going to refer, ED can't refer back to an urgent care. So then they're stuck there, right?
Great, thanks. Amy?
Yeah, that's what I was going to say earlier, is that the police and just first responders in general will need a lot of training, because the reality is they absolutely send kids who need to be in the ED, but a majority don't. And so I'm not sure, what type of training they would need. I mean, we're using, at least for suicide, the Columbia screener, and that will help determine low, moderate, high risk. So I feel like there should be a partnership between EMPS and police, at least in saying, I mean, because there's not necessarily an urgency, here we can be there in 45 minutes or less, to say, what do we have in front of us? We've been trying to work with police for years to involve us. And so I just wouldn't want to put this on their plate too much, because I think, in the years that I've been working with police, it's been a real effort to help them understand the complexity of risk, and know, is this a kid who's really low risk, or is this a kid who absolutely needs to go to the ER? If you add another level of care, I worry that we're asking too much.
Yeah.
I would also interject and just challenge the norm to what Jason had pointed out, which is traditionally you can't send a patient from an ED to an urgent care center. But why not?
Yeah.
Right. If we're truly talking a new system, well, why can't that system have bidirectional flow? So if I screen a kid in the ED, especially during this transitionary period, and the BLS provider who started last week was nervous and thought, I don't want to get in trouble, I'm going to bring this low risk kid to the ED. Why can't I re-triage him or her and say this was more appropriate for urgent care? Let's send you on over. You got your medical screening, so now the urgent care doesn't even have to do that part.
Yeah. So thank you.
Sorry.
Well, we have a bunch of hands up, and I just want to make sure you're using your hands so we could go forward. I think Lane was next.
Thanks so much. I think that one way to start would be to have some sort of algorithm or triage, like, decision tree for dispatch. So 911 dispatch. So when 911's called or 211's called, to help to determine that. Additionally, this occurs in other states. There are other states who have freestanding psychiatric emergency departments, where instead of an ambulance taking a kid or an adult to an emergency department, they take them to that freestanding psychiatric ED for evaluation. So, I mean, there might be like more concrete logistical information from other states, like Florida does it, for example. Not that we ever want to really copy Florida too much, but it does exist. And so maybe understanding how they go about that through their system logistically could be helpful. But I think 911 dispatch, giving some clear decision trees to the individuals who are receiving the calls could be the first route to go to.
Sure. So we'll go to Mickey, and then we'll go to Carlos again. But I just want to make a couple notes for Jeff. So training, workforce development, and marketing, as well as the legislation, are all integral to success here as we listen to the comments on this. So Mickey.
I just wanted to add in that, I agree regarding the ambulance. I for the last over a decade, I've been a volunteer EMT in my town. And frankly, they're all usually pretty relieved when it's a child psych call and I happen to be there, right? Because, so many of our small communities are very reliant on a volunteer workforce. And while the training is standardized and the certification process is standardized, the experience level is not, right? And the amount of training that EMS, basic life, BLS, prepared people get for psych is minimal, and for child psych is really minimal, right? And so it would be critically important. The other thing is that, law enforcement, it varies so greatly depending on which trooper shows up, which town police officer shows up, whether or not they know the child. very often it's like they'll know the child and they'll say, oh, you know, they've been to the ED at that hospital 4 times. Let's bring them to another hospital. Maybe we'll get another outcome. You know what I mean? So the training and the regulation that's going to have to be put in place around this is critical.
Yes, thank you. Carlos.
Yeah, I just wanted to get back to the point that someone else made about still having the emergency room as a place of entry, and as our main triage person to be there, and then be able to you know, screen people out and refer to the behavioral health unit. Secondarily, I mean, it would make things simpler for all the responders just to still come to one place, but we'd have somebody there to immediately assess the situation and decide whether they need to stay in the ER or be referred elsewhere. You know, the medical screening is done there. It's all there for us, as long as we don't make them wait 24 hours to see somebody who comes in on call. Then we still have, you know, quite a leg up, and we would have, you know, a nice safety net for the people coming in with either, you know, ingestions or metabolic problems mimicking psychiatric illness, whatever. So I would, you know, be in favor of doing that rather than reinventing the wheel and creating all these kind of ancillary assessment points.
Okay, thank you. I wanted to pause real quick with a time check, Jeff. We're about halfway through, less than 30 minutes left, but I also want to just make a quick comment that we have been moving forward on the planning of 988. For those of you who have not been a part of that, we have a statewide coalition, and Connecticut as a planning grant, like every state in the country. And one of the things that we're learning as 988 goes forward and pulling out calls from 911 is that law enforcement and the dispatch system on 911 are currently and will continue to be very, very protective of their behavioral health calls. And despite the backdrop in the country around law enforcement not doing well with mental health, that's not their self-perception, and they see themselves as very responsive and very responsible. So we know we have some credibility to earn with them where their expertise really lies, and they really do will need to mirror that is the responsive rates. Both 911 call answers is expectation is within 10 seconds. And then the face-to-face time when law enforcement are dispatch is very quick. So we know we have some work with law enforcement. It would need a lot of cross-training, a lot of support, a lot of collaboration. And again, there needs to be legislation. I say that because law enforcement in Connecticut and across the country, despite the 988 legislation coming, which mandates every state to have a fuller, more robust crisis service system, is that many law enforcements are adding social workers to their staff and are doing more and more ride-along. So again, there's this work parallel, like law enforcement trying to be handling mental health service calls better, and then a whole bunch of people who are saying we need to take law enforcement out of the mental health business. So that's just another point to be made. So Jeff, I don't know if you wanted to kind of move forward, or did you want to with now?
I'm finding all this to be incredibly helpful. Dr. Gonzalez, I see your hand is still up. Do you have another comment to make before we move on?
Oh, sorry, that was my mistake.
Okay, all right, just making sure. I thought that might be the case. Making sure. You know, I think this is very, very helpful. I think this referral and acceptance piece is going to be critically important, and as you can see, it has tie-ins to lots of other sections in the document, including training and outreach to each of these potential referrers. So there are lots of implications for this. I'm envisioning that we'll probably need to blow out a couple of these bullets and just be much more specific about what we mean in certain sections, and I'm hopefully taking decent notes as this goes along. We'll have the minutes as well, but this is I find it to be helpful to document people's suggestions in the margins. So
Yeah, and we appreciate those who are adding comments into the chat box. Some of them are agreeing, some are new comments. So
yeah,
it's
those
there
I
and
have not.
recorded.
Those I
We'll-
can't see right now. So Leah
Yeah,
is on call. Leah works at CHDI. So Leah, just as a reminder, if you could make sure you copy the comments and drop them
Yep.
into a document, that would be great and very helpful.
Sure thing.
Appreciate it. All right, so I think we'll in future meetings probably revisit this document, including the comments that you've been making throughout the day. So you'll have other opportunities to take a close look at
Yeah,
referral
it
and
should be
acceptance,
there.
for example. Do we want to? I was particularly interested in what people's thoughts were around physical space. I noted Steve's comment
Okay,
and others that
let me have her stay in her room, and then
somebody's on.
I'd like to make the
If you
decision
could
on
put
lifting
yourself on
after,
mute,
you know, we've
please.
seen her, as opposed to just,
Lane,
because, you know, sometimes
If everybody
when
could go on mute, please. That
other
would
staff ask questions or there's complaints from the kids, it's very
Sorry,
different when it
everybody.
comes to one of us, you know?
Lane,
So I just want to just
Lane.
have her stay in her room, and then I will,
okay.
All
we'll
right.
figure out how to make our
Leah,
way
can you
over
mute?
to.
Can you
to
mute
see
Lane?
her. I
Lane
will
Taylor
have some
from your end?
time afternoon to see her.
No, I
But if, you know, we're having to go over there to test anyway,
I don't
you
know
know,
if I
we'll need
can.
to.
All right, so we'll
you know, just check her. So whomever
Okay.
gets over there first can
Hold on
can
a
do the
second.
assessment
Yeah.
and, you know, either give me a call or I'll let you guys know.
Sorry, everybody. Lane, can you hear us?
Oh, perfect. Yeah, and then just text me what
No.
she says.
All right. Well,
Thanks. All right, bye.
Lane, can you hear us now? Lane? Lane, can you hear us?
Oh, I'm so sorry. Oh my gosh, my
That's all right.
was on. I apologize. I thought
yeah,
I
that's all
muted
right.
everything.
If everybody could go on mute while they're not on, that would be great. That's
Jeff,
all right.
can I-
Lane, we have all been there. We have all been there. Tim, go ahead.
Well, I just want to throw one more thing in. I was debating about whether to hold it to the end, but I do think we should put it on the table, and it may sidetrack the conversation, but it is an important point. So we all know, and I think we all would agree, that kids need special treatment. And what we're talking about is the child serving behavioral health urgent care. But there are a number of lifespan where the entrance in could be adult or child, and there are 2 units. So there are some out there. There are many separate entities also, adult being different than child locations or very close, but some of them are in fact connected. The reason I raise it is because on the adult side, there is huge cost savings that is associated with law enforcement diversion as a result of intoxication or low-level drug and alcohol kind of work. So I just throw that out as if people have some ideas or thoughts about whether or not we should be thinking about co-locating and being more efficient with administrative costs and brick and mortar costs with separate units. And if people have ideas about that, we could certainly think about that also.
Jason, go ahead.
I don't want this to come off offensively, so I'll precursor it with that. But I do feel like if you intermix them, the clientele of one type versus another may be very different and may defer parents from bringing kids to them, since, you know, many centers across the country like that tend to then become, in some sense, a bit of a hangout spot, which could definitely deter people. Not to be offensive, but just probably the reality of things.
It's a fair point. I appreciate that, Jason. Others, Fortunati?
Yeah, I agree with Jason that should be mindful of that point. At the same time, there would be synergies with, you know, sort of management, and that there could be significant cost savings. I totally agree with Jason, though, that just doing it for the sake of cost savings without being mindful of separating them physically in some way could be problematic.
Alyssa?
if I missed this, but when we talked about discharge above, my concern would just be discharge timing. And, we run a residential treatment program, and to get a child in within 23 hours, even now, requiring that everybody has a COVID test, I just don't know that could happen. So I worry about making sure that process happens quickly and the right systems are in place to be able to move kids out of the urgent care centers and into an appropriate level of care.
So
Seems a little ambitious, although I'm not saying ambition isn't good. I just know we don't typically move kids in within 23 hours in a COVID world.
Yeah, it's a very good point. Frank, did you have more to say on that one? See, your hand is up. Go ahead.
A question on that, because we always talk about 23 hours and, I know CMS talks about 23 hours, observation and things like that. I'm not sure that I fully understand what restricts us to 24 hours. I don't know if someone could, or 23 hours or
Yeah, good question. Tim, I think
Yeah.
that one.
So I think generally I don't have direct personal experience with any of this level of care, but what my reading of it has been is that it has to do with accreditations and a higher level of preparation. Again, if you're in a hospital, it may be less of an issue, but once you start getting off site, so that often there are still room settings, and often you have to have a day bed-like experience because kids obviously could come in the middle of the night and would potentially sleep. And again, this is where this notion that you have the combination of the urgent crisis assessment expertise, hospital level like the ED, but you also then have, again, more on the adult side, as you just indicated, or somebody earlier did, Jason, I think, they literally have what they refer to as kind of a living room, a lounge like recliners. And it's often for folks who are intoxicated or kind of low level mental health needs. And they will frequently, in fact, encourage, communication among others there to get support between and among one another. Kids are unique and don't usually have that component of it, and usually need to be kind of in a room, bed, day bed kind of scenario. But my understanding to the point of the question is, just a higher level of licensing requirements.
Lane, go ahead, please.
This is for real this time. Sorry, folks. That's actually one of the reasons why, and I apologize, have had a few calls about some issues. So I missed some of what's discussed. So this has already been discussed. Please forgive me. But that's why I think it is reasonable to think about the stabilization of 1 to 14 day units needing some direct connection, preferably without transportation from the urgent cares. Because I think that, the reality is that as much as we want kids to be able to be assessed and get on out, that I think that's a lofty goal. And to be able to have access to, we don't want kids boarding, right? But to be able to have access to respite or even some observation beds that are direct without having to then transport them to another location is ideal. And then a little bit of a tangent just while I'm speaking. Similarly, I think needing to have direct admission status to inpatient units rather than having to send to the emergency department for another evaluation would be pretty imperative.
Yeah, thank you. The direct admit is definitely clearly a requirement across, and appreciate your comments again. You start getting into facility, physical space, licensing, all those, because you're really talking about 2 levels of care. When you start combining levels of care, then again, physical space becomes challenging. So, but the notion that one of the primary dispositions out of the 23-hour setting is the 1 to 14, 15-day crisis stabilization. And again, from there, you would have still the remaining array. So a kid could still go inpatient and should also be able to be direct admit from the crisis state. You also, in some jurisdictions, have crisis respite, which is a lower level than the crisis stabilization. So there are different avenues. Some people have attempted to combine those levels of care. I think we've kind of tried to do that in Connecticut, and I think our SFIT is kind of more along the crisis respite than it is really on the crisis stabilization side in terms of the high level of acuity that could be stabilized in 1 to 15 days, 14 days. So thanks.
Let's go to Jason and then Alyssa and then Mickey.
Thanks. I think Carl actually mentioned in the chat a good point about reimbursement, and it made me think a little bit more about it. This might be getting ahead of ourselves, but when I think there's a point of clarification and then a question. The clarification question is, we've talked about this as an urgent care and not an ED, which are distinctly different in their reimbursement methods, as well as who can transport to them and not. So there are psych EDs across the country, yes, but this so far has been kind of told as an urgent care model, which is different, right? And that's just in case I'm off, if somebody could clarify that. Okay,
You're correct. You're correct.
The other aspect around that is the reimbursement. So currently, if a child sits in an ED and then is admitted to an inpatient unit associated with that hospital, so thinking if this urgent care was then owned by the hospital and then you admit to them, their ED gets $0 in reimbursement. So that fee is wiped. So then that leads to the question of how do you sustain a system like this if that's the model of reimbursement. And I understand where a 23-hour would make sense because you don't want to hold on to them for a long time, but the ED does, they hold them for 2 weeks and get $0 in reimbursement. So just something to kind of consider. The model of payment is probably very important if you're going to try and get a hospital to buy in to own one of these versus, a private separate facility.
Great, thank you.
Thank you, Jason. Alyssa and then Mickey.
Thank you. A couple questions. Have we done an analysis to determine if there's appropriate resources with crisis respite, with crisis stabilization to be able to meet the goal of getting kids in and out of urgent care centers and into the community as quick as possible? So that's one question. The other question is, and Jeff, I'm thinking about studies that I've read from your agency about many of the kids that are stuck in EDs really have intense IDD, autism related behavioral issues, and thinking about that being built into the staffing plan for these urgent care centers and really making sure that we have behaviorists as part of the staffing continuum might be an important consideration, or specific urgent care centers designed to serve kids with autism or kids with complex IDD and other issues. DDS recently put out an RFP for a step up, step down model, which is a residential model for kids with IDD that either to avoid hospitalization or to come out of the hospital. Short-term residential might be worth us looking at as we think about what are the needs of the system so that kids don't end up getting stuck in these urgent care centers. Sorry, I know that was long.
No, but thank you.
I think I might have gotten it all. All good points. There's a couple of places in training and competencies where we talk about the needs of intellectual and developmental disability,
Yeah.
but I'll add something in the staffing section and
I'll just have
your other point about discharge, like you're suggesting or recommending that we need to ensure that the rest of the continuum can actually handle the capacity of discharges out of the behavioral health urgent care to facilitate a 23-hour model. So all good. So Mickey, please go ahead.
Yeah, hi. Well, first to piggyback on what Alicia just said, I think we had all hoped that going into these discussions about really taking our behavioral health delivery system for children to the next level, that it would be inclusive, right? That it wouldn't be, well, we can treat anybody except if you have an IQ lower than, whatever. So it has to be, and the approach has to be inclusive. So I think the inclusion of behaviorists and other potential specialists are really incredible. I just wanted to add something about the lifespan approach, right? Boy, we've gotten so many calls in our office from community emergency rooms who inevitably report to us that they are not trained They are not, and maybe medically they might even have some expertise, but their nurses don't. Their support staff don't in managing kids with complex behavioral health challenges. And so, you know, but they're there. And I mean, I, you know, had calls where kids have been stuck in their EDs out in the community for weeks at a time as well. And so I really think that the cross training would be a huge, huge undertaking to be sure that everybody felt comfortable and that we all felt like it was competent. So I'm really concerned about that.
Yeah, well, appreciate that. I think that's clearly there seems to be a majority of us all sharing in the opinion of that. I just wanted to be sure we put it on the table. The issue does get to efficiency and resources and administrative issues. So that's the only thing. So but clearly we're coming down on the best practice side that
Right.
These are separate. And I also wanted to just circle back to your earlier comment. Yes, the underlying value for the entire behavioral health plan and the entire children's system and this document here on this level of care is that we are not building separate specialized services for special population, whether that be ID or DD or problem sexual behavior or others. There are certain situations where we need to be careful, obviously. But the notion would be that, again, as much as the entire service system could be competent in mild to moderate competency development across all special populations. And then so for severe and high need things, there may be some needs for specialized services, but for this level of care, the walking in the front door, the competency level of the staff there needs to be able to meet the need of any kid that walks in.
So I don't see any other hands, and like I mentioned, I can't see the chat box right now, but with the we have 7 minutes left, and I think it would be really helpful to hear, all right, stepping back from today's conversation and thinking about our next meeting and future meetings for this work group. My view is I think it's helpful. This has been really helpful to organize your comments and best practices according to the categories we have here. And I'll, like I said before, continue to clean up and update this document. So knowing that you're going to hear next week from 2 model developers, one at Bellevue, running a hospital-based behavioral health emergency department unit, and then also from Ruth Gerson, who is running also a behavioral health urgent care that's attached to a hospital facility at Northwell Long Island Jewish in Queens. So you're going to hear a lot from them next week about what they do, how their model is designed, what their best practices are, lessons learned, et cetera. As you think about future meetings, what do you want to focus on in this work group? Will it be helpful to come back to this document after next week's meeting so that we can continue to update it? Or are there other things that you think would be helpful for us to incorporate in the subsequent agendas?
I'll just insert myself as people are thinking about Jeff's questions. Jeff, I just wanted to call out, there were a number of comments in the chat box around licensing issues and funding issues. Again, those issues we'll need to tackle as we unfold this and unravel that. Clearly, there are some of those issues that DCF would have to work closely with DPH, particularly around licensing issues, and work closely with DSS around funding issues, particularly around Medicaid, and then even potentially the commercial carriers in the state. So appreciate those comments.
Tim, can I ask a quick question? Are we contemplating looking at the CPEP New York model as a potential source of this project design for us in Connecticut?
Well, I think to answer the question would be yes, we're looking at a number of different sites and jurisdictions that have implemented. We'd be open to direct recommendations as you just made, so we can certainly look at that model and others. If people have some familiarity with the model that is rolled out in particular state, county, or jurisdiction, and think it would be helpful to see their work as it pertains to Connecticut, we'd be open to those suggestions. So feel free to also shoot us some emails or suggestions around that. We did do some outreach, and Jeff was successful. We had some crossover a number of years ago with New York City folks, and so this is the fruit of that around the the whole crisis system of care in general. I think my general comment, I hope what I am appreciating about today's conversation is that people come away with today's meeting about how integral all of these levels of care are related and need to be connected directly to each other, that we need to separate and have separate conversations about all these different levels of care and what the needs are, but it has to be an efficient, very well working system, an integrated system. They cannot be fragmented and built separately. Now, again, timing and all the political processes that need to take place with all that sometimes gets in the way of that. But I think as a whole, if we agree that the best practice is that this is an integrated crisis serving system. So I just, other comments or questions back to Jeff? Is this helpful? Was this working? Are you okay with next week's meeting? Sorry, we're doing 2 months of meetings in 1 month. So we'll hear from a couple programs, see some thumbs up and a lot of head nodding. So appreciate that. Great. Any suggestions about what might be helpful that you haven't heard us talk about as a future direction? Okay. Jeff, any last minute comments?
No, I'm just glad to see that we're moving this in the right direction, and just want circling back to Tim's comment, in addition to next week's, don't think that next week's presentation by 2 model developers in New York are like the model that we want to draw from. If you're familiar with other models doing this work in behavioral health urgent care in other parts of the country, and want to make sure that I'm aware of them, I can reach out and try to get them to come in and present at a future meeting, so that you have all the information about other national best practices going out there as you can get to inform our work. So,
and I'll end with one other thought. Politically, there is, I see Gary has a hand up too. Politically, there is a strong desire for us to make concrete recommendations sooner than later. We have just come out of a strong year where kids stuck in ED was more magnified than ever. There is quite a bit of worry that the fall is going to be here quickly, and that we need to be moving in a direction rapidly. So some of this, takes time and will unfold over time. But if we can at least start to think about concrete recommendations, it's why Jeff and I are working hard about getting things down as rapidly as possible in paper, so we can present it to both the boards, the advisory board, the implementation advisory board, as well as the 12 commissioners. Gary?
And the recording of these meetings be made available? I'm noticing there's some key people that were not here. Obviously, it's vacation season, but that would be great for this week and next week.
Yep.
I'm going to try to forward some notes to some friends that weren't here, but thank you.
Yeah, no problem. And we'll post the minutes to the website, as well as the recording from the meeting for anybody that missed it. And Leah, check me if I'm wrong. These are going to the planforchildren.org website. Is that right?
Yes, that is correct.
Okay, so if you haven't been on that one for a while, this was the original Children's Behavioral Health Plan website set up in 2014. So it's planforchildren.org, either plan number 4 or FOR. I think both of them still work. Planforchildren.org is where all this is being logged.
And just as an FYI to people, that is about to undergo a complete redesign. I mean, we've been redesigning it now for a number of months, but we're getting close to that being rolled out. So if you find it a little bit clunky right now, stay tuned. That's but all of the historical work is posted there. The archives of all the information is there, and this is where you'll find the minutes and the video.
Okay. All right. Well, we are at time. And Elizabeth, I see your comment at the end there. I appreciate that. We'll definitely talk about family engagement as well as continuity between levels of care. So look for minutes to be posted in the next few days, and we will see you all next week.
Great. Thank you all very much. Much appreciated.
Bye-bye.
Thanks, everybody.
Thank you.